Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. PrabhuDev Prasad Purudappa from Boston, Massachusetts. Is an orthopedic surgeon at the VA Boston Healthcare System and also assistant professor at the Boston Medical Center and Boston University. After completing his post-graduation in PGH Chandigarh, Dr. Purudappa pursued fellowships in Mass General Hospital, Boston, Adult Reconstruction Fellowship in the University of Minnesota, Minneapolis, and a fellowship in sports medicine in the Triad Orthopedic Center. He currently serves as assistant professor in Boston University School of Medicine and an attending orthopedic surgeon at the VA Boston Healthcare, Boston. He's editor of Archives of Orthopedics Journal and also serves as peer reviewer for several high-impact journals. He's published widely across several top orthopedic journals and has several high-impact publications to his credit. If you've noticed, Dr. Purudappa has delivered a couple of lectures on a channel and has already reached a huge audience. And today it's my great honor to bring back Dr. PrabhuDev Prasad Purudappa for this wonderful lecture. Over to you, Prabhu.
All right, thank you, Hitesh. Thank you very much. So, and welcome everybody for this presentation today. And today I will be talking about dual mobility components in total hip arthroplasty. All right, so as we know, total hip arthroplasty is one of the very successful operations. It's been called the surgery of the century, and it is growing in numbers. And this information, this data from Journal of Arthroplasty in 2013 shows that the rate of total hip arthroplasty has been growing, and it's probably going to be about increasing about 174% by 2030 in US alone, and definitely growing all over the world. But it's not without complications. So this article from Kevin Boziak in JVJS, they looked at Medicare patients more than 65 years old from the Medicare database, including about more than 50,000 patients, total revision total hip arthroplasties, and they looked at the complications. So instability or dislocation was the #1 reason for all the revisions. Second one being the mechanical loosening, and infection being the third one. Similarly, there is data from multiple joint registries. This Australian joint registry from 2021 shows that prostatic dislocation was the third most common reason for hip revision surgeries. So incidence of dislocation in primary hip arthroplasty has been reported by many authors, and it varies from 0.2 to 10%. And much of this data could be from older studies which showed higher incidence, especially with posterior approaches. But most of the joint registries show about close to about 2% incidence of dislocation. And in revision total hip arthroplasty, we know that it is one of the significant risk and significant complication. It could be as high as 25% in some of the studies. And this study from Mayo Clinic showed that the incidence of dislocation actually increases with time since from the beginning of from the initial surgery for total hip arthroplasty, and they demonstrated that the cumulative risk in the first month is about 1%, and in the first year, approximately about 2%, and it continuously increases by 1% every 5 years, and amounting to about approximately 7% after 25 years. There are many risk factors. As Hitesh mentioned, I have another presentation on hip instability where I discuss these risk factors and how to deal with them in detail. These are some of the patient-related risk factors for instability of the hip arthroplasty. Many authors have reported that female gender could be a risk factor. Elderly patients, obese patients, total hip arthroplasty for femur neck fractures, patients with neuromuscular and cognitive disorders are at higher risk. Patients with hyperlaxity or connective tissue disorders and problems with alcoholism, previous hip operations, they are at a higher risk. Rapidly progressive inflammatory arthropathies and even progressive osteonecrosis of the femoral head, also are higher risk for hip dislocation following total hip arthroplasty. There's been increasing information about spinal pelvic mobility and its relationship with hip stability, and this is now a well recognized factor for hip instability. Similarly, we can classify the risk factors as procedure-related and implant-related. So there are many procedure-related factors like surgical approach, component positioning, soft tissue tension, and soft tissue repair. Surgeon experience is an important factor. And the implant-related factors include femur head size and intra-articular or extra-articular impingement. So how do we decrease this risk? So I'm going to just, quickly talk about component positioning, which we know is very important. That's why we have the concept of safe zone, which was initially described by Levinek. And we always try to get the stable component into the best possible position, trying to get the inversion somewhere between 5 to 25 degrees and inclination between 30 and 50 degrees. And this has definitely been shown to decrease the dislocation rate to from 6% to 1.5%. Similarly, we have a concept of a combined inversion. We should try to, the total combined inversion of the acetabulum and femoral component should be somewhere between 40 and 60 degrees. The dislocation rate was shown to be almost 7 times higher if the combined inversion is not between this 40 and 60 degrees. But also this study from Mayo Clinic and many others have demonstrated that just getting the components into the right position is not enough. There are many other factors involved. This study showed that almost 58% of the dislocations happened in patients with the component in the safe zone. So just the safe zone is not enough. We should try to recreate the normal anatomy and try to recreate the normal hip biomechanics, which includes restoring the central rotation, restoring the offset, the limb length, and abductor integrity. So today we'll be mainly talking about another important concept of the hip biomechanics, that is the head and neck ratio, which has been demonstrated by many authors to be an important factor in improving the stability of the total hip arthroplasty. So head size has been demonstrated to be very much related to the hip stability. Increasing head size given a constant neck thickness, that is increasing the head neck ratio, improves the range of motion of the hip joint before the impingement happens, thereby decreasing the risk of dislocation. So as you can see here, smaller heads, a smaller arc of motion, and bigger heads with a bigger arc of motion before they start impinging onto the stable component. And many registries have also shown that there is increasing trend or increasing the increase in the number of arthroplasties using larger femoral heads. As you can see here, 32 size femoral heads probably are the most common ones being utilized. Next one being the size 36, and size 28 as probably the third most common one being utilized. So another concept is the jump distance. So this is the amount of lateral translation of the center of the femoral head before the dislocation occurs. So that is that corresponds to the distance from A to B. That is the amount of displacement the central femoral head has to happen before the head starts coming out of the socket. And again, increasing the femoral head size will increase the jump distance, thereby potentially decreasing the risk of dislocations. So dual mobility concept was actually started long ago, sometime somewhere in the 1970s. So we had the modern total hip arthroplasty developed by John Charnley in 60s and 70s, where he utilized size 22 heads and polyethylene as the bearing surface, which improved which decreased the friction So this was called low friction arthroplasty, and thereby decreasing the wear of the polyethylene. But the main problem was the hip instability. At the same time, many surgeons were also using these stems, many of the more monoblock stems with large heads of size 32, with either a polyethylene liner or a metal cup. The McKee was the metal on the metal, the type of bearings. This definitely improved the stability, thereby decreased the dislocations. But their problem was increased wear, thereby increasing the polyethylene wear, and if it is metal on metal, increasing the metal on metal debris and all the problems associated with metal on metal arthroplasties. So in 1970s, Professor Gils Bosquet and his colleague was an engineer. They came up with this idea of dual mobility, where they tried to combine these two concepts of the channel-less low friction arthroplasty and using the large femoral heads, which was the concept of making infrared metal and metal arthroplasty. So they tried to use this monoblock type of a stabler component and use a femoral head, which was typically a size 22 head with a large polyethylene layer, which snaps fit onto the femoral head, which then articulates onto the stabler component. So this increased the head size, and also there are two articulating surfaces, thereby increasing the range of motion of the hip joint. So the dual mobility has two articulations. The first one being between the femoral head and the polyethylene liner. So this is where most of the range of motion happens. This is where the initial engagement occurs during majority of the range of motion. And the second one between the polyethylene liner and the stabler component. So this starts engaging in extreme range of motion. Thereby, this dual mobility increases the head-neck ratio, thereby increasing the range of motion and also increase the jump distance, thus decreasing the risk of dislocation. So as we can see here, there were problems with the stabler component fixation initially. So Professor Bosquet, he experimented with various designs to trying to improve the stabler component fixation. Because unlike today, we have the modern porous-coated components with press fit. They didn't have the best press fit ability at that time. So, and also it was monoblock, so they were not able to use the screw fixation. So he had to try different techniques to improve the stability of the stabler component. So finally, they were successful in improving the design, and the first generation of dual mobility involved a 22.2 metallic head articulating with a polyethylene liner like this, which then articulated with a stabler liner. The shell was a stainless steel shell coated with porous plasma sprayed alumina, and it had 3-point fixation with the 2 pegs one going to the pubic ramus and the ischium, and a bicortical screw fixation like this into the iliac, into the iliac. And the polyethylene liner was ultra high molecular weight polyethylene, which was gamma sterilized. So they did demonstrate significant improvement in the stability, thereby decreasing the dislocation rate. Professor Bosquet himself in '86 showed that in his series 136 cases, 36-month follow-up, 2.2% dislocation rate. And Boyer in 2012 reported on first generation dual mobility components with no dislocation, a 22-year follow-up in 240 hips. But there were many problems. They had the problem of catastrophic polyethylene wear because of the issues with the initial polyethylene, and also a unique complication of interprosthetic dislocation, wherein the polyethylene layer separates from the femoral head and it comes out of the socket and dislocates into the soft tissues while the femoral head is still inside the stabler socket. And like shown here, and third one being again the problem with fixation of the stabler cup. Increased polyethylene wear was a problem in first generation dual mobility components because of two surfaces here between the two articulation surfaces between femoral head and the poly and the stabular component. And also the polyethylene sterilization techniques were different at the time. So there were higher polyethylene wear problems. But the recent designs have significantly improved on this. And this study in 2017 demonstrated with an in vitro simulator, the wear performance of dual mobility components was similar to a standard bearing total arthroplasty. And this review paper in 2017 also demonstrated that improved polyethylene fabrication, adoption of thinner and smoother trunnions, and chamfered polyethylene liner rims have significantly improved the wear rate and reduced this problem definitely over the short and the medium terms. Interprosthetic dislocation, as I mentioned, it was a significant problem with initial designs. So this is a conventional dislocation where the entire head comes out of the socket. And this is what happens with interprosthetic dislocation. It's because the dissociation of the outer polyethylene head from the inner femoral head, which is secondary to degeneration of the polyethylene retentive rim. As you can see here, normally the polyethylene is like this. Over a period of time, it wears out, then it loses the snap fit from the femoral head. Thereby, it comes out of the femoral head, and then it slides out of the stabular component. So these were many of the studies were from before 2010, and this definitely they demonstrated improved dislocation rate, as you can see here, but the interprosthetic dislocation rates were significantly high, almost 3 to 4%, and some studies almost 5% incidence of interprosthetic dislocation. But this also has been improved significantly in the recent the modern dual mobility components. This study by Levin in 2018, 693 dual mobility revision total hips reported an interprosthetic dislocation rate of just 0.2% at 31 months. And this systematic review of 54 articles, including 10,000 dual mobility primary total hips at 8.5 years, reported no case of interprosthetic dislocation after 2007. And but prior to that, the incidence was 3 to 4%. And most of these first generation, they involved femoral head size 22, but the modern designs, they typically include a 28 size femoral head. So the contemporary dual mobility design has a standard stabular component with a cobalt chrome metal liner, which snaps fit into the stabular shell, and then a polyethylene liner, which snaps fit onto the femoral head. We had to use a device, something like this during surgery, to snap fit femoral head into the polyethylene liner. And of course, the femoral head then fits onto the femoral neck. So there are many studies have shown that there is increasing trend in the use of dual mobility, both in primary and in revision total arthroplasties. This is from American Joint Replacement Registry from 2013 to 2018. The utilization in primary hip arthroplasty almost doubled. Similarly, in revision arthroplasty also has been increasing in the last decade. So what are the current indications for dual mobility component use? So revision total arthroplasty is definitely has been demonstrated by many authors as an important indication, especially if it is done for instability and abductor deficiencies. Primary hip arthroplasties with high risk of dislocation, like in total arthroplasty and femur neck fractures, neuromuscular diseases and cognitive dysfunctions, conversion total hip arthroplasties with abductor deficiencies, stiff spine, like patients with lumbar and lumbosacral fusions, and oncologic reconstructions. Dual mobility in revision total hip. So we know the incidence, the risk of dislocation in revision total hip arthroplasty is really significant. So it could be anywhere from 5 to 30%. Many studies have shown that. So this study in 2018, including 355 revision total hips for any reasons, they compared between the two groups, the dual mobility group and a large size 40 head group. The dual mobility group had a 3% dislocation rate versus a 10% dislocation rate for the group which had the 40 millimeter heads. And the revision for dislocation was 1% in the dual mobility group and was 6% in the other group which utilized the 40 millimeter heads. The total hip arthroplasty and femur neck fractures again has been demonstrated by many others to carry higher risk of dislocation. And a study by Iorio in 2001 showed a dislocation rate of more than 10%, which is nearly 5 times that of total hip arthroplasty in standard osteoarthritis. So this study in 2012 utilized the dual mobility component, demonstrated 1.4% risk at a short-term follow-up of 9 months, including 214 patients. The study compared between the dual mobility and standard conventional total hip, and the risk of dislocation was 14.3%. The incidence was 14.3% in the conventional total hip, and no dislocation in the dual mobility group. Stiff spine, again, as I mentioned, there has been increasing amount of literature regarding this topic, and it's been well demonstrated now that patients with stiff spine, like shown here with the fused lumbar spine, the fused lumbosacral spine, have altered mobility of the pelvis, thereby they are at high risk of dislocation. So the study from the Medicare database with total hip arthroplasty in patients with lumbar spine fusions, it included more than 15,000 patients. There was a control group of about 800,000 patients. The dislocation rate in the control group was about 1.55%, and patients with the spinal fusion rate was those patients with 1 to 2 levels of fusion, it was found to be almost 3%, and those patients with 3 to 7 levels, almost 4%. So dual mobility components have been shown to improve the stability and thereby decrease the risk of dislocation in these patients with fused spine also. Patients with oncologic reconstructions, again, the dislocation rate in these patient group is high, anywhere from 10 to 40%, and many studies have shown that dual mobility components improve the stability and thereby decrease the risk. In this study with 71 patients, both lesions of the hip, utilized total hip arthroplasty with dual mobility. There were 7 dislocations, accounting for 9.8%, which is still higher. When the abductors were preserved, it was 3.5%. When the abductors were sectioned or reattached, it was close to 10%. And if the gluteus medius muscle or the nerve was resected, it was close to 18% risk of dislocation, even with the use of dual mobility. Patients with neuromuscular disorders like cerebral palsy, Parkinson's disease, and elderly patients with severe dementia, they are also at high risk of dislocation, and dual mobility components have been shown to improve the stability and thereby decrease the risk of dislocation in these patients. But as we discussed earlier, again, dual mobility has some complications and concerns. Interprostatic dislocation is still a concern. It has been significantly improved with the modern designs, but still there is something which needs to be kept in mind when we are using these components. Aseptic loosening of the acetabular component, again, we talked about this. This also has improved significantly with modern porous-coated implants, which can be press-fitted, and also a metal liner which can be snap-fitted into the acetabular component. And some authors have actually recommended supplemental screw fixation for all the acetabular components when we are going to use a dual mobility to decrease the risk of aseptic loosening of the acetabular component. Accelerated PU wear, polyethylene wear, and associated osteolysis, again, was a significant factor in most of the early designs. This also has significantly decreased in the present-day designs. Especially, we have to be more careful in patients, in younger patients with less than 50 years of age, because they are more active and they have a higher risk of polyethylene wear. So in summary, so total hip arthroplasty, if it is a revision total hip arthroplasty, and we can definitely consider utilizing a dual mobility component, especially if the revision is being done for instability. And in oncologic resections, again, this has been shown to improve stability, and it's a good indication. Primary total hip arthroplasty, those patients with higher risk of dislocation, like the ones we talked about, total hip arthroplasty and femur neck fractures, patients with neuromuscular disorders, and patients with spine pathologies, and any other patient who is considered to be at higher risk, utilizing dual mobility is a good indication. Young patients less than 55 years of age, posterior approach, and patients with morbid obesity, there is not enough data at this time. So one has to use clinical judgment before considering the dual mobility components. In patients in primary arthroplasty with no risk factors, no risk factor, a conventional total hip arthroplasty should be utilized. Okay, that's it. Thank you.
Thank you, Prabhu, for yet another brilliant presentation. Prabhu, you can stop sharing actually.
Okay. Let's say stop sharing.
Yeah.
All right.
Prabhu, yet another brilliant presentation, and great work in Boston. Couple of questions from our side.
Sure.
Now, the biggest advantage of a dual mobility is in two group of patients, right? Those who have a neurological disease like Parkinson's, and fracture neck of femur, isn't it?
Yeah.
Okay, so if we have such great results in these conditions, why can't we extrapolate this to general population? So someone undergoes a THR in less than 50, or what is the concern? Is it revision rates, or is it wear and both surfaces? We have dual interfaces, right?
Yes, that's correct. So like I mentioned in a couple of the slides over there, so we still don't have very long-term data on these younger patients, and that's always a concern. Like when we offer total hip arthroplasty for a younger patient, for conventional total hip arthroplasty, we always say, hey, you are at higher risk for revision because they're more active compared to someone who is elderly. So that because dual mobility have more volumetric wear, which has been demonstrated in some of the studies. So that is still a concern, even though in the last couple of decades with ultra high molecular polyethylene with vitamin E and a better different sterilization technique, the incidence of polywear has decreased, but still that is a concern. So if somebody is not at a high risk of dislocation, probably at this time, conventional total hip with a conventional ceramic and poly is still the standard bearing.
And Prabhu, imagine someone who is 65 years of age, who has a fracture, and you believe that he's a community ambulate around. What is your preference? Is it a dual mobility or a standard THA?
Can you repeat the first part again? There was a little, how old was the patient?
Yes, around 65 years of age, male.
Okay. Uh,
Yeah, he's a
yeah.
community ambulator going around and with a
Mhm.
fractured neck of femur. Would you prefer dual mobility or a standard THA?
Dual mobility, of course. Yeah. So 65-year-old displays femur neck fracture. Typically, I tend towards totally arthroplasty. Many studies have shown that the function is better and also lower risk of failures as compared to an osteosynthesis. But they definitely have been shown to be higher risk of dislocation. So dual mobility is a good indication in that patient.
Okay. And just one more question from our side. Do we have enough level 1 data on this particular subject, dual mobility hip replacement? Is there enough level 1
So
data? RCTs.
I don't have that. Most of the studies are from the registry data, and most of them are retrospective reviews. I don't think we have any level 1 data at this time.
Thank you, Prabhu. I think you have gone through this particular topic in detail, and there's not any room for much questions. And we have already covered this particular topic in detail in the past, and that's why we have no more questions on this particular topic. Fantastic talk, and I'm sure this is going to benefit a lot of people. Thank you so much, Prabhu.
Thank you, Hitesh. Thank you. It was my pleasure.
Bye bye.
Thank you.